So I'll make, I have made last minute changes at 9 p.m. I cannot talk about no trials and trials and trials. So the talk about salivary gland tumor and HER2 positive subset. So last year in the month of February or March, this 62-year-old gentleman came to us. He was hypertensive and presented with the right-sided neck swelling. Relative of one of our radiation oncologists, Dr. Nikhil Kalyani. He had already, the report of FNAC, which was suggestive of adenocarcinoma, and he came for the second opinion. Dr. Rakesh is our head and neck surgeon, and we usually do discuss the cases in MDT, though we are no freelancers. And then we did the clinical examination, and there was a sternal induration. Now, salivary gland tumor is a it's a heterogeneous subset. On the one end, there are dormant tumors. On the other end, there are very aggressive tumor. This patient was actually, was posted for the surgery. We, asked them to wait. And after the discussion, we, repeated the biopsy, not the FNAC. And it was a joint decision. And this previous, so initially it was a high-grade carcinoma and AR positive. So usually those patients come AR positive, we become happy and try manipulating the hormonal things with leuprolide and bicalutamide. But we insisted on ER, PR and HER2 because the PET. So this is the data about HER2 positivity in the salivary gland tumors. On the one subset, you have up to 50% positivity, especially those are high-grade tumors. On the other end, you have very low HER2 positivity, less than 0.1% in adenoid cystic, which is a dormant tumor. So the biology is very, very important over here. So this was his PET scan. Patient was absolutely fit, and there was tremendous cutaneous disease, bone disease. The primary is also bulky. Patient had liver disease too. So this is what happens with the high-grade tumors and aggressive tumors. See the necrotic large rounded lesion in the liver with high-grade activity at the periphery. So basically, this tells about the aggressiveness of the tumor. And such patients, even if you get AR positivity, you should try and get HER2 markers for high-grade tumors. As you have seen that the HER2 can be positive of the tune of 50%. So these patients, we started with the systemic therapy, and the patient was affording. So we started pertuzumab, trastuzumab, and taxanes. He responded clinically. So what is the data? There is no level 1 data of phase 3 trials because the numbers are very small, and I will quickly run through this. This is HER2 positivity by Her2 and FISH. What we should try if your clinical document says this is a high-grade tumor, you should use both the modalities, ISC as well as the FISH, and newer techniques like NGS to define this HER2 subset because they do respond very nicely. See the plot. You have only few patients progressing, and rest all are responding. Very few with small stable disease, and maximum with partial response and complete response. So getting this subset diagnosed very properly with all the modalities is very, very important. Again, this is numerical numbers for the CR and PR and progression disease. So in the tune of 80%, you have clinical benefit. More than 80% patients showing clinical benefit. Thank you, Dr. Vijay, for this slide subset because getting into head and neck, especially rare tumor, is very difficult for general medical oncologists. So he has helped me with the slides. So again, another study where 16 patients treated with HER2 targeted therapy. You can see those 15 patients who were defined by ISC, NGS, and FISH, and there is one patient who was HER2 mutant. So many times nowadays what is happening, most of these patients exhaust with the systemic therapy and then go for NGS. Fortunately, we have many labs in India, but our confusion increases with those labs. Some of those labs give the therapies what to use, but those combinations are beyond our imaginations. So in HER2, but the things are very clear. As our experience in breast cancer and gastric tumors and cholangiocarcinoma, these patients do respond if you pick up them, including the mutated patients. Here you can see that one patient had a stable disease, but rest all 15 patients have some response to the dual targeted therapy. The previous study was only trastuzumab, and this is trastuzumab and pertuzumab. So majority of the patient again in this stage responded. Very few progressive disease. The only thing is these responses are not does not last. These response Since are not lasting long, then you have to be careful using one first line, second line. Keep those HER2 targeted therapy like breast one after the other. This is the progression-free survival, and this is the median overall survival. These patients live longer up to the year of 2 or 3 years if you keep using the systemic therapies one after the other. Now in breast, we have these agents, TDM1 and trastuzumab deruxtecan. Oral agents are coming up. Their utility in other cancers like head and neck cancer, we don't know because the experience is going to be anecdotal or case-based series or small series. What in this particular series, what they have done, 10 patients with HER2 amplified salivary gland carcinomas were treated, and the median age was 65. The median lines of prior systemic therapy was 2. And as we know, the systemic therapy is also very limited: platinum, paclitaxel, docetaxel, minorelbine. So here the overall response rate again was 90%, including 5 complete responses after prior trastuzumab and pertuzumab. So if you use TDM1 after pertuzumab and trastuzumab, still you have the possibility of getting good responses. These patients, some of these patients have been subjected to anti-androgen therapies also in the form of leuprolide and bicalutamide. After a median follow-up of 12 months, the median duration of response not reached, median PFS not reached. Toxicity including grade 1-2 infusion reaction, and we can manage the toxicity of TDM1. You have to be a little bit careful with the platelet count as well as the interstitial lung disease. If the patient shows symptoms, you have to evaluate them for these particular symptoms to rule out the interstitial lung disease. Then this is the case series of docetaxel, trastuzumab, pertuzumab as a first line and TDM1 as a second line in a recurrent metastatic HER2 positive salivary gland tumor. So here what they have shown, again, this is the first line and second line. In the first line, they have dual HER2 therapy. Majority of these patients, if they are lucky and early detected, the best therapy is for them is surgery followed by the adjuvant RT most of the cases. Very rarely, if the margin is positive or any high-risk features, we add chemotherapy. But eventually, high-grade patients do relapse and then they come for systemic therapy. So situation is these patients have already been subjected for surgery, radiation, and the situation is palliative. So what they have used again here is IHC and FISH to define the HER2 status. So this graph is very important. These patients do have limited therapeutic options. And if you place these options one after the other, what the graph has shown that there is a possibility that you can get the maximum depth of response and duration of response with amalgamation of systemic therapy, which is chemotherapy or androgen deprivation therapy, and with HER2 targeted agents. Again, those HER2 targeted agents, you have to place one after the other. Where the red blocks are showing the dual targeted therapy, trastuzumab and pertuzumab, and the green one is TDM1. And there is a possibility that using treatment in such way, you can prolong the ultimate overall survival. So these are the patients getting those responses. The best possible response in the first line is PR, few CR, and very limited. There are no progressive disease. But with the TDM1, you can see you have 3 progressive disease and 4 PR. So the best drugs in our line, both whether you can go ahead with the dual HER2 targeted therapy, what we do in breast cancer, or those patients who wants to avoid chemotherapy because you combine HER2 targeted therapy with docetaxel and you can use TDM1 without chemotherapy. So sometimes patient choice also important. So our patient, as I'll go back to the previous slide, after 3 cycles, patient has excellent response. Sorry for the. So this is after third cycle, docetaxel, pertuzumab, trastuzumab. This patient has a fantastic response. The skin and the liver lesion completely gone, the bone lesions completely gone. But after a median of 2 years or 18 months to 20 months, what happens in breast? HER2 positive breast cancer with a heavy systemic burden, they have a tendency to relapse in the brain. And that exactly happened with our patient. This patient last month only came with imbalance. And the MRI was done, and there was a single lesion, dural-based lesion, quite big. But we discussed with the neuro team, we did the PET. The systemic disease was absolutely in complete remission. And this was the only lesion. Now, there was a dilemma whether to operate or no, to do radiation. We discussed both the options. Our radiation colleagues only told, no, because we have 18 to 20 months of response, let's resect and then give radiation. So this patient underwent resection. After resection, the performance status has improved significantly. Now he's walking without support and subjected for RT. RT just finished, and we have continued pertuzumab, trastuzumab. The most important thing, we have not exhausted the pertuzumab, trastuzumab, knowing the fact systemically it is doing better. Rather than jumping to TDM1 right now, let's utilize the local therapy, what we do in lung cancer also. On oligoprogression, we use RT or surgery. Here we have done exactly the same. Hopefully, he should get another PFS2 of a year, and then we can go ahead with the TDM1. So basically, in the palliation, this is what options are available. If you do NGS, you get some targets, and based on that, like MTRK, you have targets available, but it is very rare to get those targets positive in salivary gland tumor. Neoadjuvant and adjuvant, still it is under research. Looking at the responses, there are not going to be a neoadjuvant trials of Her2, but if you have a patient, our surgeons are now ready to operate after our intervention. Usually what surgeon do, give some chemotherapy, then I will see. This is what happens in the head and neck, because in India, patients comes very late. So again, we don't know the answer if the patient has a locally advanced disease, whether to add Her2 in the neoadjuvant setting, because even the platinum was better in these patients. So we don't have the answers for the neoadjuvant adjuvant, but for Her2 targeted therapy in salivary gland tumors, we should make every attempt, should utilize ISC, FISH and NGS to pick up those subset of patients, especially for the high grade. And for that, to know the history, how long the tumor is there, how fast. That's okay. So that is very important. As in our particular case, we insisted on PET scan because the way it came up, the biopsy was high grade salivary gland tumor, and then we insisted, in spite of getting the AR positivity, we did not aim for using only hydrogen, and this is the result where the patient is living beyond 2 years. Now we don't know whether he will continue to respond with the dual Her2 target therapy, but the quality of life is important, and that is good in this particular case. So thank you, the organizing team, and thank you for those who are sitting here and listening to me at 9:20. Thank you.